We've entitled the talk, thanks firstly to Clin and the rest of the Exco for inviting me to speak on this. I must disclaimer first that I'm no expert in medical education, and neither am I an expert in the medical humanities, but I'm kind of like here because we all have that common interest and passion as well. And so it's something that, I was kind of like asked whether I'm interested to embark on. And kind of like along the way, I've already been doing some of these things because of my own personal and clinical interest as well. Right, yeah, but really no expert. So I hope that this brief presentation will be more of a discussion. Please feel free to jump in with your comments. And it's just a summary of some papers really that review this topic of integrating the medical humanities in medical education. Right, so I've entitled the talk What, Why, and How. Right, and I hope that at the end of this session, after all the discussion, we'll be able to have a kind of more common understanding as well, and to also have that dialogue, right, on how we can overcome some of the challenges in integrating the medical humanities in our medical education, as well as health professions education and ongoing continuous professional development. Right, so first we start off with a quote, right? So there we have Hippocrates, right, who is the father of medicine. When Hippocrates famously said that whenever the art of medicine is love, right, there's also a love of humanity, and I think that's the essence really of what the medical humanities is all about, right? Whatever we want to define it as. Right, so a brief outline of this session. Right? We're talking about firstly what the medical humanities is, so that we have that common frame in our mind, and why briefly touching on why the humanities are important in medicine, and what the medical humanities can bring to medical education, and how can then we incorporate the medical humanities in medical education. And first we end off with a discussion. So, Pellegrino, right, one of the forerunners in the medical humanities as early as the 1984, right, once wrote that medicine connects technical and moral questions in its clinical decisions, right, and is required to be both objective and compassionate. And it exists between the sciences and humanities, being exclusively neither one nor the other, but having some qualities of both. Right. I think that in essence encapsulates what many people have been sharing, right, this morning and up till now in this whole retreat. And so I think I really like this quote. Right. And so just to help us all be on the same page then as to what we are talking about here, right? So the medical humanities actually can be defined, right, as an integrated interdisciplinary approach to understanding the human condition, right? Not just of illness, but also of health, in order to create knowledgeable and sensitive healthcare providers, patients, and caregivers as well. Right. So earlier on, Natalie was also talking about how it's important to engage caregivers as well, right? And I think society at large as well, to create that common understanding and shared experience actually of going through illness and restoration of health together in our system. And so the humanities actually draws on creative and intellectual strengths of diverse disciplines, right? And I think the list there is non-exhaustive, right? But Clin includes literature, art, creative writing, drama, film, so on and so forth, right? And all this is really what the common underpinning there is the common pursuit, right, of the goals of medical education, right? Which this morning actually Andrew was speaking on. So what are then some of the challenges in 21st century medicine? Right? So we've heard a lot about evidence-based medicine, and in medical school, and when we're doing our specialist training, or even in the other healthcare professional training, right? We always hear about evidence-based practice, right? But really, how the challenge is, how do we cultivate and preserve, right, the necessary balance of technology and science with humanistic care and caring, right? In other words, the art of medicine. Right, and in fact, evidence-based medicine, as many have already shared, right, is really reductionistic. Right? It tempts us to describe people in terms of data, right? Research data, statistics, right, that derive and generate biomedical science. But that is really insufficient for what we call whole person care. right? So really evidence-based medicine alone cannot be the full and holistic practice of medicine. Right? It can be said that it's kind of like EDM is like alphabet, right? But without the art of medicine, we don't have the language, right? And so if we have alphabets without language, we can't really have a common, we can't really communicate, right? And be on the same page with our patients. So what do the humanities offer medicine? Right. So I think they offer and Mann said that elements of physicianship are anchored in the arts and humanities, and it helps us to form deeper connections with our patients, and also to maintain the joy and meaning of the practice of medicine, through actually also developing empathy for our patients, right, and also resilience on the professional front. Right, and integration of the humanities and arts in medical education can support learners in developing many different kinds of qualities, right, that we want to see in our healthcare professionals: professionalism, self-awareness, better communication skills, and the capacity for reflective practice. Right, and so the ultimate goal really is for the humanities to help clinicians cope better with and to reduce stress, mitigate burnout, foster resilience, and promote greater well-being. Right, and in a not too long ago, in the American Journal of Ethics, right, Jones said that a complete medical education includes the arts and humanities. Right, so what then can the humanities bring to medical education? Right, so we can think of some very broad categories, right? Humanities categories, right? Like for example, in literature, right, it can challenge the readers, right, of literature to see the world from the perspective of another, right? And we know very well that Kun, in order to help his MOs, right, rotating through his department, foster greater empathy for patients, right, in the palliative care setting, right, uses the novel The Death of Ivan Ilyich, right, as one of the tools actually, to foster that reflective capacity and perspective taking. Right, and just looking through some of the literature as well, right? I've read that students can encounter various kinds of dilemmas, right, in clinical practice, right, and also through reading certain books, right, it helps them actually whenever they encounter difficult situations in clinical practice, right, to have sustained thoughtful reflection, right, as well as the chance to appreciate and reconcile multiple perspectives, right, and that in essence is what actually we do, right, when we read, whether we are conscious of it or not. And so in real life kind of a clinical day-to-day clinical practice, right, that helps us to be better prepared as well, right, to respond, to think on our feet, right, and sensitively as well whenever we encounter real life kind of clinical dilemmas on the wards. Right, then music, of course, we know that Dr. Dave also, who was previously heading the team, right, he used I can't remember which composer it is now, right, but basically some classical music, right, to train students, actually medical students, to in cardiac auscultation, right, and on top of that, actually, right, I think like I personally learned the piano, right, and I remember last time when we're learning Baroque music, right, and Bach, right, Baroque composers, basically when you play the piece, right, or you listen to a Baroque piece as well, there are actually many different voices in there, right, and so one actually is able to kind of like through active listening actually listen to the different kind of tonality and voices, right, in the music. And likewise, that also helps us to, in clinical practice, I think that in a certain sense can also train our mind, right, to focus on different aspects as well of what's going on in the clinical consultation, right? So to see the many different kind of layers as well as to what the patient is telling us, right, when they narrate their stories as well of illness. And then we go on to art. I think art interpretation, right, has also been written about in the literature. It can foster greater teamwork, right, improve communication, curiosity, and questioning, right. So in some of the literature that I've gone through, right, for example, a certain kind of there are certain workshops, right, where a whole department can attend together, right, in art appreciation or interpretation. And through those kind of discussions, right, it helps us to see the perspective of our colleagues, right? Things that, sometimes we don't notice in an art piece that someone else picks up. Right? And likewise in real life clinical practice as well, right? That's what we call the collective wisdom, right? Where when we come together, right, put different kind of minds and experience together, right, that actually helps us to be better clinicians, to see things from multiple perspectives. And then anthropology and history, it teaches us about the diversity of human experience, right, across time and space, and it encourages us to reflect seriously on our own values and perspectives. Right? For example, history, by asking students to consider carefully the mechanisms of disease change over time, right, can open their minds to complex interactions between individuals and society at large, and how these actually influence different perceptions of doctors, patients, families, and society on perhaps the efficacy of certain treatments, right, or even the value of medical care. Right. And so we can see that, even like during the COVID pandemic as well, right, that's still ongoing. Right, if we pay attention to the media and the literature as well, right, we can see that there are different kind of diversity of views, right? Even things like whether you're for vaccine or you're anti-vaxxer as well, right? And all these things actually, in a certain sense, manifestations actually of different people's kind of values and culture. Right, so then how can the medical humanities be introduced into medical curricula? Right, so I think there are various kinds of approaches that have been written about in the literature as well. Right, so of course there's the integrated versus elective kind of approach. Right, so integrated would mean that they are kind of like incorporated into the curricula and day-to-day practice. So much so that sometimes it's not something that is so intentional, right? But it's rather something that's ongoing, something that people may not even realize that's ongoing, right? But I think there's also importance in making some of these things, right? Making intentional making explicit the implicit, right? And on the other hand, there are also elective programs, right, where people can opt to come for a retreat and webinar like what we are doing right now, right? But of course, these you will have a kind of selection bias, right? Because then these are the people who are naturally interested in this, right? And people who are not interested or don't think that this is important will not turn up. So I guess there's a downside to that, right? Because then you're kind of preaching to the converted. But then also there are things, other approaches like, strategic slotting into available teaching sessions, right? And a broad range of initiatives as well have been used, right? To help incorporate medical humanities into the curricula, right? Like reflective practice, cultural humility, to foster greater critical thinking skills, so on and so forth. Right, so just to share then from some of my own personal experience, right, in the community mental health program that we run at CGH, right, how we actually use, for example, movies, right, to foster greater awareness as well and understanding, right, of mental health problems in primary care providers as well as various other community partner social service organizations. Right, so we know, right, using from movies as well, much has been written about using movies as part of medical education, that it's been used in various disciplines, right, not just psychiatry. And movies really, they transcend age and cultural and professional boundaries as well. Right? What they do, a movie can really evoke strong emotional responses, stimulate reflection, and engage learners in discussion as part of the active learning process. Right, so at CGH, what we have done actually in the past was that we have these Psychiatry in the Movies events, right? These are some of the titles that we've shown, right? As the alternative platform really, to teach community partners to recognize and manage common psychiatric conditions, and also stimulate that kind of discussion space, right? To talk about like medical, legal, and ethical kind of issues. Right, so these sessions actually we show a movie, right, in the past, and then after that we have a post-movie kind of a discussion session that is led by a facilitator, right, and we get the audience to share their reflections on what they've learned and observed over the session, right, and we also then ask thought-provoking questions about, certain kind of like ethical dilemmas, for example, right, or social issues that are portrayed in the movie. Right. So just to break the monotony, right, I'm going to show one of these, a short clip actually, right, on from this movie still at least. I'm not sure whether you're familiar with it, but basically it's a movie, right, about Alzheimer's disease, right? So Julianne Moore, as you can see here, right, in the movie, she's a psycholinguistics professor at Columbia University. And at the height of her career, a very successful career, she starts to develop symptoms of dementia, right? She finds that herself missing flights, appointments, having word finding difficulty in lectures, right? And mind you, right, she's actually a linguistics professor, right? And through the movie, actually, we see very riveting scenes, actually, right, of how her decline actually is something that she has to grapple with. And her own family members as well, her husband, a medical doctor, and her children have a lot of difficulty coming to grips with that, right? How she's no longer the person that she used to be, right? But this final scene, right, is that of her youngest daughter, who was initially kind of like estranged from her, right? Who eventually became her main caregiver, right? I think it's an extremely poignant scene that I would like to show you. So just give me a moment, and I hope I can put this up.
Moon across America. God, it's been years since I was on a plane.
Can we hear?
When we hit 35,000 feet, we'll have reached the tropopause.
Yes, it's a little bit soft.
Oops.
As close to the ozone as I'll get. I dreamed we were there.
Sorry, let's pause it and okay, I'm sorry. I think that's probably the loudest, but I'll share the clip later on if you can't hear. But let's try again.
God, it's been years since I was on a plane. Belt of calm air. As close to the ozone as I'll get. I dreamed we were there. Plane leapt the tropopause. Safe air and attained the outer rim, the ozone, which was ragged and torn, patches of it threadbare. It was old cheesecloth, and that was frightening. But I saw it's been years since I chased the moon across America. God, it's been years since I was on a plane. When we hit 35,000 feet, we'll have reached the tropopause, the great belt of calm air. As close to the ozone as I'll get. I dreamed we were there. Plane leapt the tropopause. Safe air and attained the outer rim, the ozone, which was ragged and torn, patches of it threadbare. It was old cheesecloth, and that was frightening. But I saw something only I could see because of my astonishing ability to see such things. Souls were rising from the earth far below, souls of the dead, of people who'd perished from famine, from war, from the plague. They floated up like skydivers in reverse, limbs all akimbo, wheeling, spinning. And the souls of these departed joined hands, clasped ankles, and formed a web, a great net of souls. The souls were 3 atom oxygen molecules of the stuff of ozone, and the outer rim absorbed them and was repaired. Because nothing is lost forever. In this world, there's a kind of painful progress, longing for what we've left behind and dreaming ahead. At least I think that's it. Hey. Did you like that? What I just read. Did you like it?
Mm. 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 Mm.
Mm.
Mm.
And what was it about?
Love. Yeah, love.
Yeah. It was about love.
Right. Okay. Yeah. Before we carry on, I'm just wondering whether there are any kind of thoughts or reflections actually about that scene. Well, was it clear what was going on to everyone?
I think it was alright for me.
Sorry.
I think it was alright for me.
All right.
Yeah, thanks. Understand what was happening.
Right, thanks, Inko. But actually, more importantly, I think, was there any kind of thoughts, on, I think it was a very poignant scene. If you watch the movie, you're probably better able to appreciate why it was so poignant.
I don't think I watched the movie. Might have read the book, but I forgot. It's kind of similar in a way to Wit. Someone who is in the study of language in one of his forms and losing that facility, and her daughter trying to connect. So that's what I kind of took away from it. And then I think the special thing is that for dementia patients, sometimes unexpectedly they can wake up, and the Humanities is a way to reach them. I don't know if anyone saw that clip about Tony Bennett, and he's got dementia as well. He's got Alzheimer's. And Lady Gaga actually made an attempt to have a concert with him, and nobody knew whether he would turn up on that night. But when the lights went on, the curtains went up, he was able to perform like he was before. And it is those moments that really spark hope for the caregivers, I feel. Yeah, so I think that would be the value of that, even if they feel that their loved ones are quite lost to the ravages of the disease, that, that there's always still hope that, someday they might make that connection.
Right. Thanks, Natalie. Any other thoughts? I'm just curious.
Maybe I'll just add as well. I think sometimes what the clinicians are not so able to pick up, right, is actually the whole planning of the scene, as well as the angle of the cameras, and also the kind of music that's used. Because basically it's actually an immersive experience, right, for the viewer. And there's probably a lot of effort and thought going into that already. So I wonder if anyone has any experience or even the expertise to comment on that.
Definitely not me. Yeah, thanks, Prof. Khan. Yeah.
It's not expertise, but I was just going to share a similar experience, or maybe a for instance. I don't know if you're familiar with Second Life, which is one of these platforms where you can enter into this sort of, it's part of like the metaverse, where you can become an avatar in a virtual world. And a few years ago, we did some work looking at patient perception around social stigma around psychiatric illness. And there's a very powerful one on it. I don't know quite how these things work, but there's an area in Second Life, which I'd have to dig out the link for, but it's where you can walk through this space. It's like a room or a series of rooms. It's a building type thing. And as you walk through the space, there's different artifacts in the space which give you the experience of, or reported experience of, being a schizophrenic patient. So the paintings start talking at you or about you, or there are other sorts of things that change as you move through the space, which you take it at one level and you see, just an ordinary picture of a portrait on a wall, and then it talks at you or starts persecuting you or making you sort of paranoid. And it was really, it's sort of some of the things that we've been speaking about over the last 2 days about walking in others' footsteps. It's about having some of those perceptions. I still remember this takes me back. I still remember the first patient I ever clerked on my first medical firm. He was a little man who had sadly had a midbrain stroke, so he had locked-in syndrome. And I can't tell you how profoundly that affected me. I just didn't know this thing existed, this type of syndrome. But I still remember that gentleman lying in his bed, and he could blink his eyes, so you could ask him questions. And he was clearly there. He just had this body that was just not him anymore, or not under his control anymore. So it was sort of a bit like what we were talking about this morning, about profound challenge of weird, and also just seeing a human experience that was so out of keeping with your own experience. Here was somebody who was obviously alert, could respond, could take questions. He would even cry sometimes when you asked him certain questions in certain ways, but he couldn't move. And that man lay in that bed for the whole 3 years of my clinical training. He was one of the first patients I ever saw in my first medical placement, and sadly he just died just before I was going to be the houseman on that firm. The 3 years later, but it was, this sort of notion of walking in another person, having an experience in another person's medical predicament, which you cannot but imagine until art or, this is where the Second Life was quite interesting. It gave a very interesting experience of what it was like to be schizophrenic. So I don't know. I think it opens up new opportunities for education. I think it offers up new experiences that can really powerfully give people a sense of authentic patient-related experience, particularly if we listen to patients who explain or try and convey or use these medium to convey. Actually, I was just thinking I think I've explained I was a chronic pain consultant, and one of my patients was an artist, and she did this beautiful series of pain images around chronic pain. And one was of a sort of desolate wasteland. Another was of a hand imprint in the beach, but with a hand formed out of ice, for some of the symptomatology, burning, scorching hot. You imagine putting a blowtorch on a piece of barbed wire, and the image of a piece of barbed wire with this glowing red barb. And she produced this book of really powerful sensory images. Some of them were about creepy crawlies, and some of them were about heat. Some of them were about sharp and pain and desolation, and that book was you try to convey how desperate or desolate some of these patients are to students or others. I tell you what, if you see that book, you don't have to look much further. It really just does convey. So I think there is some power in giving people the opportunity to walk in the feet, the shoes of others, which I think is really powerful and quite an important part of both empathy generativity, but also understanding beyond what our normal experiences, because most of the students come from reasonably affluent or protected backgrounds, and they why would they? They can but imagine. They cannot but imagine. Like they can't imagine the broad sweep of human experience that is disease and pathology. So I think anything that we can use to bring it to life and make it more accessible or personal for them has got to be a good thing. So I don't know. I think there's so much potential in this space for helping students better understand all of these areas, and I think we're only starting really to harness it.
Right. Thanks, Prof. Karan, for your sharing. Absolutely agree. I think what you're referring to really is like that lived experience, right, of illness that our patients go through as well. And I think nothing quite kind of better encapsulates that than a good movie, right? Because it evokes so many of our senses. I remember in a psychiatry conference that I attended some years back as well, they had this like a virtual reality thing, something like what you went through as well, right, where you can kind of experience hallucinations and things like that when you put on this headset, right? There's nothing kind of quite beats that, right? In helping one to be able to empathize with what the patient is going through. And so I think it just this scene that I just showed as well, I thought it was just so poignant and ironic that the choice even of the poem, right, that the daughter was reading to this her mum, who was obviously quite advanced stages of dementia and could probably barely understand what she was reading, right, was actually like referring to things, longing for things lost and stuff like that, and all the many different losses that she had to grapple with, right, as she saw her mind and her body degenerate, right, but yet that whole kind of human experience, right, of the daughter relating to her, just being there, coming alongside her, doing something that she would probably have enjoyed so much, right, in the prime of her life when she was well, right. I think that communicated so much more than the content of that poem, right, and that's where Julianne Moore was able to respond and said that was about love. Right? I think that's the essence also of how we want to create the ability in ourselves as clinical practitioners and the students as well, of being able to communicate that empathy to our patients through being there with them, right, and to be able to understand their illness experience and to relate to them at that level. Right. Okay. So before we get carried away, let me just finish up the last couple of slides. Then we can have a longer discussion. Okay, so having discussed some examples, right, of how the medical humanities can be incorporated in medical education, of course, then we have this problem of assessment, right? How do we assess that? Because in medical education, we are always kind of very preoccupied with assessment, and of course, to justify its inclusion in the curricula, right? There's often calls.
Can you your display? You're showing us your speaker notes.
Dr. David, you're muted.
I'm sorry, am I still showing the speaker notes?
Oh, now there's nothing there.
Okay, let me see. I'm sorry. Okay, can you see now?
Perfect. Thank you.
Right. And are you able to see the speaker notes now?
Yes, now
Yes.
now the first one was correct. Now you're in the speaker notes again.
Okay, I'm not sure why that's the case, but never mind. I don't really need the
See, you
speaker
just
notes.
click the display and flip.
Okay, can you see that?
Yes, that's right.
Okay, good. Right, so I think we always talk about the need for assessment, right, or outcomes, examining outcomes as well. And in so doing, there are calls for the outcome measures to be more sophisticated and rigorous, right? But of course, then the challenge is that, we all know that the humanities is something that is difficult to judge effectively by the standards that we set for evaluating, technical competency, right? For example, like how well a student does a lumbar puncture or IV cannulation, right? How we can't judge students with or evaluate students with that same kind of rubric, right? When we actually, perhaps evaluating a piece of reflective writing, right? After going through a palliative medicine or psychiatric posting, right? And so quantitative methods really, I think, fall short, in that sense. But then, there are calls for using greater kind of qualitative methods, right? But again, this is something that's really challenging and labor intensive. I think Clin can probably testify to that as well, right? That a lot of work goes into kind of recording down, interviews or focus groups and things like that, and then breaking down that information as well. Right, so various people have used different kinds of means to try to assess the impact of the humanities on medical education, right, such as close observation with feedback, reflective portfolios, right, to assess really what we are looking at is the process, right, of learning in arts-based interventions. Right, so just at a glance, right, some of the research findings of the impact of medical humanities in medical education. Right, so students have been shown to have greater empathy scores. Right, art making has been shown to increase understanding in relation to the self, patients, pain, suffering, as well as the roles of doctors, right, in healthcare. Students also have been found to have improved interpersonal communication skills and humor, right, in terms of perceptions, attitudes, self-efficacy, and behavior. And formal art observation training as well has been shown to improve medical students' visual diagnostic skills. Right, but then really, right, again, some of the challenges, right, in collecting objective data is because of the fact that, part of the essence of the humanities is the sense of intrinsic value, and that's something that's non-measurable, right? And we can't really measure, right, the emergence of pleasure or unexpected insight or even wisdom. We can't do that very objectively. And so, can really then the benefits conferred by training in the humanities be measured somehow? So that's something I think for us to think about and discuss. And also then the greater kind of philosophical question, right? That is medical education nothing more than a series of competencies, the attainment of which can be measured by an improvement in a skill. Right, so here are some emerging topics in medical humanities in medical education from the literature. Right, so global health and medical humanities, right, has been used to foster greater cultural competency in an increasingly globalized world. We've also been moving away from just focusing on doctors, but also nurses and allied health professionals, right, to improve the interdisciplinary understanding and collaboration. Technology, right, has been used. So digitization, blended learning approaches, even in delivering patient interventions, right, as Natalie presented earlier on. Also pre-health education initiatives have been come up with, right? So for people who are pre-medical school, right, some of them actually go through some of these programs, right, to assess their suitability or for them to perhaps reflect on whether a medical career is something that is suitable for them. Right, and also there's also been talk about including medical humanities training, right, throughout the professional life trajectory, right. So that's the continuous professional development that we're looking at, and also a very big thing, especially right now, right, greater focus on mental health and burnout during the ongoing pandemic as well. Right, so how medical humanities can actually improve resilience, well-being, and reduce burnout. Right. So this is just an example also of some resources, right, that are available in other centers overseas, right? Like this bedside education in art of medicine, right, where it's delivered actually through an app. Yeah. So they can select visual art or poems and then browse them by certain categories, right? And then to find a particular piece that one can relate to. And then after that, there are certain kinds of reflective prompts, right, for clinicians or patients.
Sorry, is it just me or is everything a little blurred?
Is everyone else okay? Sorry. Let me just try to reshare that.
I can see a big black block at the top.
Oops, there's something wrong with Zoom this afternoon. Can everyone see my screen again?
Yeah, but the block is still there.
Oh, I think sometimes it's a bandwidth thing. Yeah, it's like a blurry block, right?
Dr. David, do you actually have something like, the screen sharing box? So if you actually get it to go away, the box will disappear.
Close everything down and open it up.
Sorry, how do I do that again?
I'm
sorry. I think all these problems started after I showed the video.
How do I describe this? Okay.
Can you reopen up the PowerPoint presentation?
Yeah, let me try that.
Just close it all down and open it up again and then share from scratch again. That sometimes works.
Do you want us to share it for you?
No, it's okay. I actually amended the slides a bit. So, okay, is this better? Still not?
So if there is that screen sharing box, right? If you get it to go up, the black box will disappear.
Screen sharing box. You mean the
Zoom toolbox?
Yes.
So if you get it to...
How do I get it to go up actually?
You click off screen maybe.
Yeah, I must have pressed something accidentally just now. Speaker, full screen. Yeah, I think it's because the bar, right, with all our faces is on top now. I'm not sure how I get it to go down.
If you can't get it to go down, maybe you could try to minimize it.
Yep, let me try to do that. Sorry. Does this work now?
We can't see anything.
Can you see this now?
It's coming up.
Can you see my screen now?
Yeah, it's still pixelated, so you can't see.
Okay, let me just try to...
Now has more bars.
Sorry. I apologize for the technical problems. Let's try that again. Is this better?
No.
Actually, Dr. David, why don't you just don't full screen it? You just expand the slides in the PowerPoint itself.
Okay, can you see this now?
Oh, that's clear. That's
okay,
clear.
I know why. It was the video optimization that was on.
Oh.
Okay, now we all learned something.
That's clear.
Yeah. All right. Yeah. So we can see this example, right? I was talking about. This is an app actually that has been developed overseas, right? Where we have all this content that's curated, and then either patients or providers actually can use it, right, at the point of care as well, right? Various kinds of art pieces, for example, right? And then you can choose something that you can relate to, and then there's certain kinds of reflective prompts, right? Like, how does this visual art poem relate to your experience of illness for the patient, right? Or how does it relate to your patient's experience of illness as well? And then they can even share it with or email to other team members. I thought this was wonderful. Okay, so this morning, I think various colleagues have spoken about narrative medicine, right? About the work of Rita Sharon at Columbia. And I think that's something that really strikes a chord with me as well. Like what Andrew also was speaking about, right? Hearing patients' narratives, right? And listening to their stories, right? And so Sharon basically says that right, the effective practice of medicine requires narrative competence, right? That's the ability to acknowledge, absorb, interpret, and act on stories, right? That and the plights of others, right? So right, and basically, right, it's based on the premise that every patient has a story that goes beyond the symptoms that they bring into the patient's office, right? And these stories actually can illuminate how the person became ill, right? And also the various kinds of challenges, including social challenges that they face in getting better. Right. So clinicians likewise, right, have their stories to tell, right? From their interactions with patients in the course of the work that they do. Right, we are also human beings with our own feelings, right, and our thoughts. And so this is a picture actually of a Berlin group going on, right? And that's something that I'm quite hot on as well. It's something that our community mental health program at CGH also does with general practitioners in the community, right? So it's a reflective space really, whereby clinicians come, right, and they share their stories actually of patient encounters, right? And the focus really is not on it's not on the diagnostics, right, or the management of the patient, but it's really of the dynamics that goes on between the doctor and patient, right? So some very memorable kind of stories that I've heard our primary care providers share as well. For example, in a recent one, right, there was this GP who was talking about how he actually does some nursing home work, right? And he sees patients like what Prof. Karen described, right? Some patients with locked-in syndrome, those who are post-stroke, and they are kind of bed-bound. Some are actually non-verbal or in advanced stages of dementia, right? And he was sharing about how he felt sometimes about the futility, right, of some of this work that he does in the nursing home, right? Because basically you're not able to kind of connect with patients verbally as well, right? And so that space actually opened up a lot of discussion, right? And actually brought up a case of a patient who was actually dying of cancer, right? But her family had actually who doesn't even visit her, right? Was actually getting the doctor, pressurizing the doctor to collude with them to keep her diagnosis keep the diagnosis from the patient, right? And he would describe how she would have multiple kind of somatic complaints, of pain, bloatedness, nausea, and she would ask him at times, doctor, what's wrong with me, right? But yet he's unable to kind of reveal the diagnosis to her because that's what the family says. She mustn't know about this because she won't be able to deal with it, right? So having such a reflective space, right, to talk about the clinician's own experience, right, and the emotions that they have to struggle with when they in the course of their work, right, in such difficult kind of clinical dilemmas, right, I think it's something that can be really therapeutic as well and help to protect against burnout, right? And Schwartz Rounds are largest kind of scale events, right, which are actually hospital-wide. We don't actually have this in Singapore just yet, right? I got to experience this when I was doing my fellowship in Columbia actually, right, and in New York City, and I think it's again a very powerful platform, right? So medical students, various healthcare professionals. You have a few hundred people streaming into an auditorium, and they actually one of the sessions that I attended, I remember sitting next to a medical student, right? They were actually talking about a patient with Munchausen syndrome, right? So that for those of us who are familiar with that, it's a very severe kind of condition where a person has that need, right, to be under the care of healthcare providers, right? So they'll do all sorts of things to their bodies to feign illness, to get themselves hospitalized, and oftentimes they have underlying psychiatric issues as well and a lot of social problems. And this lady eventually succeeded in, accidentally rather, right, ending her own life in the hospital because of certain things that she did to get herself admitted. And so this platform actually, they got various healthcare professionals to just share in various ways, right? Some shared through a poem, some shared through their just own reflective piece, right? On their experience, right, in caring for this patient. And then after that, the facilitator actually, opens up the floor, right, for people to share their reflections and their thoughts. And I remember the student who was sitting next to me was actually kind of like blown away by the whole experience, right? Because this was a space where even senior clinicians, right, allowed themselves to be vulnerable, right, and to talk about the struggles as well, right, that they face in, grieving over the loss of this patient and, not having been able to help her, right, in the way that they wanted to. And again, that's something that I think Andrew spoke about this morning as well. Right? So in conclusion, I think the medical humanities can play an important role in helping healthcare professionals reconnect with the heart and soul of medicine and to equip them to provide holistic, person-centered care in the 21st century. Right? And integrating medical humanities and medical education can support integrating the humanistic and scientific, right? And ideally, of course, this would optimize the well-being of both patients and healthcare providers. Right? But as spoken about this morning as well, in the discussions, I think the medical humanities really needs to be something that's relatable, accessible, and applicable as well in day-to-day clinical teaching and encounters. And for us to be able to cater to a very kind of a diverse audience and needs, right, flexibility is required. Right, so so with that, I'd actually like to open up the floor, right, to discussion. Right? I think these are just some questions that I had in my mind as well, on what are some of the challenges that we face in our own institutions, including the medical humanities in, medical education and CPD activities. And also, I think the more kind of a philosophical question, right, about whether, is medical education simply about competencies and improvement in skills or empathy scores?
Thanks, David. I think it was a very helpful presentation to really list out a summary about the different aspects of medical humanities in medical education. Is there anyone who would like to ask any questions or comments before we tackle these two questions? Anything about the talk so far?
I mean, one thing I would say is you're having experience of both Bauer and Schwartz Rounds. It's really important to be able to build a psychologically safe environment. I know we've talked about this a couple of times already over the last 2 days, but trust and psychological safety are prerequisites for these, because otherwise they are inappropriate methods if you can't create that trust and openness and psychological safety. It's I think they're very powerful if they're done well and effectively, but they, like any intervention, that they can be quite harmful and damaging if they're done inappropriately or in a poorly prepared way. And particularly, again, it goes back to the points that we've reiterated several times: the real importance of faculty being well prepared for these interventions. They've got to come from a place of appreciative inquiry and psychological safety, and that's quite an advanced skill set. I mean, psychiatrists and psychologists would have those skills as a matter of course, but many other clinicians have to develop them, and it doesn't come easy. So it would just be a caution as much as anything. We shouldn't just start doing these things without proper preparation or proper planning. I don't know what David's thoughts are on that.
I absolutely agree with Prof. Karen that I think the execution is really important, and being able to create that safe space. I think for Berlin groups which are smaller scale, it's much easier to do that, especially when you have a close group, like where the members are familiar with each other, and you feel kind of psychologically safer as well, less threatened, like when you don't have unfamiliar faces coming in. I think Schwartz Rounds are a whole different ball game, right? Because it's, you have anybody can come in. It's a large auditorium, hospital-wide kind of event, and yes, I think absolutely. Sometimes you may have people making perhaps insensitive comments or things like that, and the facilitator really has to be able to handle that on his or her feet. Yeah. Interestingly, the leader of the program in the hospital that I was at, right, was a cardiologist, not a psychiatrist or anyone. Yeah. Right. But again, I thought he handled it quite well because there were certain comments as well that I thought were kind of bordering on being too technical or clinical, right? And I felt that I think definitely training needs to go into this. So there are training programs actually to equip facilitators to be able to do this in a very sensitive manner.
Maybe we can ask Andrew. He's watched a lot of talk show hosts. He's probably learned a lot.
I think Andrew has left the session actually. Anyone else has any other questions?
Maybe I'll just quickly add, maybe not a question, but just a comment. Me and my colleagues were stepped out for 2 hours because we literally just finished our own faculty development. And Crystal, who I think is on, she just gave a fantastic talk on narrative medicine. I think Enku knows her. So again, the first question, what challenges do you face? I think for a lot of us in our PJCP, I think they might be somewhat skeptical. So again, instead of bombarding everyone with what articles, I think again, we are a very self-selected audience here, right? We are interested in it, so hence we are here. But I think the risk I fear is then bombarding people who may not be interested in this. So literally, since the end of Crystal's talk at 2, and in the last 10 minutes, I've just learned how to set up a Telegram channel. I've made it private. I've just created an invite link. Because I know when it comes to work emails and stuff, it gets very messy. So essentially what I'm going to do by the end of today is send out this link to my whole division. And this is the link. If you're interested, join. If you're not interested, it's okay. Because then I think, we want to get those interested on board, and hopefully the word of mouth thing will spread. Maybe we'll report back on this sometime in the future.
So actually, one other thing, it's maybe a provocative thing to say, and I'm not saying this in any undermining way. There's a lot of clear utility and value in all of the things that we've discussed over the last 2 days. Do we have to advocate it as humanities in medicine or medical humanities, or is it more a barrier to adoption? It's for discussion. It's not a fully formed conclusion I have. And why I'm saying that is, for sometimes you see people put up barriers or hostility to things that they consider to be a little bit more left field. People talk about these things being fluffy or psychobabble, or they use terms of derision to rubbish or undermine. And the reason this came out is, I've seen inappropriate sorts of behaviours in both Schwartz Rounds and other type of fora where there isn't psychological safety, or the fundamental behaviours are suboptimal, and there's an abundance of suboptimal behaviour in healthcare, unfortunately. So we're trying to, I don't know, the value proposition to me would appear to be, thinking on the hoof here, that we want a more humanistic approach to healthcare and healthcare education in its most general terms. To me, feels like the value proposition. The how, we're going to use access to this wide range of devices and creative processes that we've been sharing over the last 2 days, but to achieve that more sort of humanizing of healthcare. I don't know if that makes any sense at all. We don't have to call it medical humanities if it produces another barrier to adoption. That's the only reason I'm saying it. It is what it is, and I'm not wishing to in any way devalue it. But knowing the way some people view this type of approach, particularly when they take a very rationalizing, reductionist sort of logical, scientific approach to medicine, and that, you know, as an educator for a long time, and as a clinician for 30 odd years, the scientists do think the educators are flaky. And part of it is because of this more humanistic element within education. And I think it's this sort of, it's almost a dichotomy between the sort of logic and rationalization of science and the more socio-cultural, ethical and sort of, it's logos versus ethos versus pathos is what I'm sort of trying to get back to. And the question is, it's in our advantage to not put barriers to the adoption of those things. So I don't know, maybe those are incomplete or unformed thoughts, but I mean, I know it's a good rallying point. I mean, much of what we've talked about would also sit in human factors. A lot of it would also sit in, you know, psychological safety literature and all of the those sorts of things. So does it have to be called medical humanities or humanities in medicine? I'm just asking it, and I don't wish to in any way undermine any of the great work that's been done or presented. It's really to ask us to focus on, is this a means to an end? And is that end more about humanizing healthcare? Is that the true goal, the true North Star? I'm just wondering. Any thoughts?
I do sort of agree with that. You know, maybe if we try not to make it so distinct, like, okay, now we're going to talk about this thing called medical humanities, but kind of incorporate it in together with medical education, even into talking about different pathophysiology, you know, just put in a little bit of medical humanities into it, and without really saying, like, drawing everyone's attention that, okay, now, you know, we're going to really change focus. And I mean, it's not something totally different. We want the learners and the trainees to feel that, it's very natural to consider the aspects of medical humanities in our education, and not just doctors, but also the nurses. And so David, I just wanted to say that I was so happy to see in one of the slides, I think that the humanities needs to be spread across to also, like, you know, nurses, the allied health professionals, and one of the big benefits of medical humanities, I really strongly believe in, is the part on interprofessional communication and how to work with different professionals, healthcare professionals, which all of us do day in and day out. I really think that humanities can help in that area.
Thanks, Joanna. I realize that we've overshot. So thank you so much for all your comments. I think there is a lot to ponder about. David, thanks again for presenting.